Good evening, doctors.
Yeah, hi, good evening.
Yes. Hello.
Good evening, sir.
Yeah, good evening, Amshi. How are you?
Good, sir, good. Can I just share my screen and see if it works?
Yeah, I have allowed the participants to share the screen, so you will be able to do it. Just let's test it. But, sir, one more thing. One second. In the PPT, like when you're asking the questions, I think the doctor or the panelist should be, the speaker should be in view, not the screen. So like maybe you can like start with this and like this first screen and introduce the panelists, like yourself. Because there's no visual represent, it's just text. So I think it'll be better, more impactful if like if Dr. Ranga is speaking, that he's visible, and if
Can we do something like a PNP kind of thing?
sorry?
Picture in picture kind of thing? No.
So you will be visible at the side, like a side thumbnail would be there, but it would not make sense. I think if it's a gallery view, all the panelists are there in the view, that will be better.
Can you just show a presentation in such a way that the screen is minimized and only 3 of us are being seen?
Yeah,
Can you modify
I'll
that?
just WhatsApp you the last link, you can just see.
No, I understand what you're saying. What I'm saying is when you're broadcasting it from Zoom onto Facebook,
Right.
you can modify it in such a way that they'll be mostly.
No, sir, we cannot do that.
No, we cannot do that.
So that Zoom does not allow us to customize that thing. So we want you guys to be there on the screen so it will look more interactive.
All right, I'll do one thing then. Let's not do a screen share then. When you are launching, you just continue with us, with only the 3 of us being there, and I will see my screen on my side and I'll ask the questions. Is that how does that sound?
Yeah, that makes more sense. Generally, like this is the pattern that we follow, unless there is a visual, like a single speaker usually, you know, has a PPT, like with Dr. Amit, I think we had last on COVID-19 FAQs. He had a PPT with all the visuals and video and, you know, graphic representation. Because textual, I think people get, like, there is no engagement. Like we've seen that, like people don't enjoy that, seeing that.
Okay.
When there is a personal people connect, you know, when somebody is saying like a
absolutely
doctor.
fine.
Yeah.
Absolutely, I understand. I have put some graphics, but I take your point. Maybe you wanted more graphics then.
Yeah. And like maybe
in the morning.
next time, like whenever we have.
You should have told me in the morning. That's why I sent it when that it should be more or mostly graphics or something to read. Then I would have done that more. Okay, no issues.
Yeah.
So we'll just do like that. And I will not present any screen. I will just start off, but that thing will be there for my understanding and for my.
Yes. All right. Once we have, I'll in any way, like before starting, I will tell you that we are going live, so you can start saying. It will directly be casted on Facebook. So I'll mute myself after saying that, and then you can continue.
And you're introducing everybody, right?
No, you have to do that. I will be on mute only.
Oh, okay. Then I think sir should do it. I mean, he's a senior person. Wouldn't that be better?
No, generally the moderator sir introduces. So today we are live with Onco.com to discuss the topic. And I am so-and-so, and we have with us Dr. Ranga and the other doctor, and then you can.
Sure. Okay, fine.
Dr. Piyush will join at 5:05. He has some urgent this thing. So I'll start the live and he can join in later. You can introduce him later.
Okay. Fine. Sir, you're right now at Paras Medical, sir? Or?
Yeah, Paras Hospital, Paras Cancer Center in Gurugram.
Paras Cancer Center in Gurugram. Okay. And the introduction, sir, Colonel Rangarao. Is that okay?
Yeah, Dr. Colonel Rangarao, whatever way you want to say.
Okay, so that's it. Whichever you say, sir. Okay, I thought this part would be done by Diksha, so I was not thinking about it. Okay. Right. Yeah. So, sir, did you get a chance to go through the slides, sir?
Sorry, I didn't. We will see that.
No problem. This is mostly what we discussed yesterday.
Right.
I've just sent you again. You can just check and go through once more. And mostly the things we discussed yesterday only. I don't know if I missed anything. You can just go through it once.
And at the closure also, Dr. Vamshi, like you can just say that, thank the other speakers and then thank onco.com for connecting like all of you for having this discussion. You are on mute. I can't hear you.
Yeah, fine. We'll do
Yeah.
that.
Nothing else, I think. Introduction. Like you, because I will be on mute, I'm not part of the live. It is a panel discussion of all three of you only.
So this is better, I think, in terms of lighting, right? Or should I leave the lights on?
It's getting reflected in your specs, so the light.
So the previous one was better?
I think so. Pallavi, what do you suggest?
This one is better, Saloni.
One is better. Okay.
You are on mute, doctor. Yeah, but both are fine.
Doctor, you are on mute. Yeah,
Both
this
are
is fine.
fine.
This is fine. Yeah.
Fine.
So it's 4:56. At 4:59, I will start screening it live, like the process, and then you can start exactly at 5. And you'll only be visible on Facebook if you have your video and audio on. So like at all times during the Facebook live. So we'll be going live. So if you can unmute and switch on your video also, Dr. Ranga, you can start in 3, 2, 1.
Good evening, everyone. I am Dr. Vamshi Krishna. I am the head of medical oncology and hematology at the AIG Hospitals, Hyderabad. And it's my pleasure to invite you all to this meeting on immunotherapy. What are the common myths and the opportunities for immunotherapy in cancer today? With me, I am very lucky to have an extremely distinguished panel. Colonel Dr. Ranga Rao is the head of Department of Medical Oncology and Hematology at the Paras Medical Center, Gurugram. And we'll be shortly joined by Dr. Piyush Bajpai, who is a esteemed medical oncologist and hematoncologist. Today, we will be talking the next 40 minutes or so about immunotherapy, where we can use immunotherapy, why is it really in the news, and what are its good points and what is the bad point about immunotherapy. I request all of the audience listening in to kindly send in your questions by chat. Just a request, personal doubts about treatment is not something we would like to entertain here. There's a different platform for it, but any general doubt you have about the immunotherapy and where it works and how it works would be more than welcome, and we would be happy to sort your problems out. So let me start off by asking Dr. Angarao a very philosophical question. So you're one of the most senior oncologists in India. And what do you think has really changed in the last 20, 30 years of your practice? How has oncology changed in that time?
Yeah, so thank you very much and very good facilitations to each and every person in the audience. And then thank you, Vamshi, for introduction and then asking me this question today. Okay, so in the last 30 years that I have been in a solid oncology practice, what things have changed drastically. Things have changed drastically in the sense that the whole, it's not just the things have improved, but things have improved in everything, the diagnostic. I mean, we worked in the era when CT scan was just coming in, MRI was not existent, and then we were depending upon the the conventional CT, what do you call conventional radiograms and all that. So we didn't have anything. When PET scan was very far off thing. I mean, that was not even in the theory at the moment. So those are the days. And from there, imaging, for example, has taken off completely. The various invasive procedures, the bronchoscopy, the gastroenterament, everything, diagnostic and therapeutic procedures have changed completely. The the treatment has changed completely. We had very few chemotherapy medicines, and today we have not just the chemotherapy medicine, but we have the targeted therapy, the huge arsenal of targeted therapy, and then something new which is called as immunotherapy, the combinations of it. The surgery was at its shall I say now, not in infancy, but it is very well developed. But today we have a lot of different kinds of surgery, including the robotic and the laparoscopic, and then less extensive surgery, but yet radical surgeries. And then radiotherapy. Radiotherapy has undergone complete change. The equipment, the science is completely as if it's packed into one particular machine. And then the whole rays are delivered with such great accuracy, with focused things, least affecting the side of the the organs which are existing on the side of the target organ. So I think things have changed a lot. Coming to the results have changed a lot in the sense that now patients are benefiting a lot in terms of they're surviving more number of patients have been cured, less side effects, and then but the cost has gone up tremendously high. And in the early 90s, when one of the important molecules, the interferon came in, that was one of the costliest molecule we had, and today we don't even see it in the market. And then now we see much costlier molecules, and then every molecule which is coming is costly. Unfortunately, that's the truth. Behind every science there is a lot of money, and the discovery, there's a lot of money. And then for them, all these molecules are expensive because we have to pay for their science and everything. So unfortunately the cost has gone up high, but yet people are benefiting a lot from this. So I think things have changed immensely for the benefit of the patient.
I have to agree with you, sir. I mean, you have been so much more, but in my short time of practice, around 12 years, I remember when 12 years back I was in All India Institute, we actually did not have a thoracic oncology department which was specializing in lung cancer. You know, we used to think that,
Yeah.
oh, lung cancers, the outcomes are so poor that, you know, giving chemotherapy or not giving chemotherapy is practically the same. And today, I think lung cancer is one place where the treatments have multiplied, the outcomes are so much better. Today, if I get a patient with a stage 4 lung cancer, I can actually tell them that, no, you are looking forward to a few years of life. And that kind of a change has been pretty revolutionary I think in my practice. And frankly, 10 years back, I would not have imagined it. I can just imagine how much you have had a ringside view to all the changes that have happened in oncology. Right. So can I ask you another question, sir? What exactly is the way we interact, or what do you tell a patient who comes to you nowadays with a stage 4 malignancy? How would you start telling them? Would you say the same thing that we used to say, that, you know, it's stage 4, nothing can be done? Or would you be now more optimistic or hopeful for the patient?
So to be honest, the way we tackle the patient, I mean, it is very, it doesn't happen all the time that we talk to the patient right up front. We mostly, the relatives themselves, they come and say that please do not disclose everything to the patient first. You tell us, and then we will slowly talk to them. And then I encourage them to make me talk to the patient in fullest possible extent. And that's how I've been doing. So it doesn't happen like in the West that, okay, fine, you tell the patient fine straight away that, you know, you are having a stage 4 cancer and you have very few months to live. I don't think in India that kind of a thing happens, unless the patient is very educated and then very bold to understand and then he wants to really know how long he's going to live. So we mostly tell the relatives first, explain to them everything, the options, the benefit of each and every treatment. And then when the patient comes, we tell them in brief. And then if the patient is understanding and demanding, then we disclose as more information. That's the way we do.
So I think these are words of wisdom, sir, which has come out of your experience. Dr. Piyush, I welcome Dr. Piyush. Dr. Piyush is a medical oncologist and hemato-oncologist from Manipal, Delhi. So Dr. Piyush, we were just talking of how radically oncology has changed in the last 10, 15 years, and not to speak of 30, 40 years, where, you know, we were having a scenario with few drugs, and now we have a spoiled for choice, and the outcomes are being reflected in that. So what do you think when a new patient comes to you? How do you start telling them that, you know, things are better? Of course, we have to understand, like sir was saying, that sometimes we are a little, I would say, not as economical with the truth as we should, a bit more economical with the truth when the patient is there, but with relatives, we certainly talk a lot more. How do you see this change in your practice?
So thanks, Dr. Vamshi. You rightly pointed out that yes, things have changed, and things have changed in the past decade, in 15 years that we are seeing, and a lot of this change has come because of the precision medicine that we have realized, and that's possible after that the DNA level of analysis can now be done for the tumor. So now that we have some good targeted therapies, we can use them to the maximum potential. So because of this, we are seeing that certain diseases, for example, lung cancer, which were actually poor survival in advanced stage, the survival has got better. But I would not say that in all subsets, we are still making progress. But a lot difference has happened than what was 10 years back. There are a lot of subsets which have improved. Yes.
Okay. So since you brought out this topic, what exactly is this targeted therapy? You know, this is something common. And patient walks in, they say, "Arey, humne targeted therapy ke baare mein suna." You know, that's the commonest thing we start hearing. Somewhere, somebody will say, "Doctor sahab, targeted therapy ka kyun nahi bata rahe ho?" So, you know, can you just, as an explanation, tell us what exactly is this targeted therapy that we talk of?
So
in a simple words.
यस, सो टारगेटेड थेरेपी बेसिकली अगर हम बात करें तो अगर कोई ट्यूमर है, उसमें अगर उसके सरफेस पे कोई अगर प्रोटीन्स होते हैं, उसके अगेंस्ट, उसी ट्यूमर के अगेंस्ट स्पेसिफिकली कोई दवाई, जैसे कि इमैटिनिब है CML के अगेंस्ट, सो उस पर्टिकुलर मॉलिक्यूल के अगेंस्ट कोई दवाई, अच्छा वो मॉलिक्यूल किसी और हमारे शरीर में जो सेल्स होते हैं उसमें ज्यादा मौजूद नहीं होता, तो ये टारगेटेड थेरेपी मेजरली ट्यूमर सेल्स पे ज्यादा एक्ट करती है और ट्यूमर सेल्स को ज्यादा डिस्ट्रॉय करती है। जैसे कीमोथेरेपी होती है तो वो ट्यूमर सेल्स पे तो प्रहार करती ही है, बट बाकी और भी ऑर्गन्स पे करती है, साइड इफेक्ट्स लाती है, जैसे कि हेयर लॉस होता है। बट टारगेटेड थेरेपी मेजरली जो ट्यूमर है उस पे जो मेजर फाइंडिंग, जो मेजर प्रोटीन्स होते हैं उस पे जो है ज्यादा एक्ट करती है। सो दिस इज पॉसिबल बिकॉज ऑफ प्रिसिजन मेडिसिन।
So, Dr. Rangarao, you know, prahar karte hain, war karte hain, a lot of war words and a lot of fighting words which we are using. So, you know, there's a simple example explanation which Dr. Nevin Murray had used, and he said uh, targeted therapy is like a smart bomb, whereas normal therapy is like a cluster bomb. What do you think? How would you put it? Would you think there's an apt description?
I would agree to a lot. And then actually cancer treatment, जो cancer का treatment हम लोग करते हैं और एक जंग में लड़ाई होती है, इसमें और उसमें कोई खास फर्क नहीं समझता हूँ। एंड देन जैसे वहाँ पर एक जंग में, एक मैदान में हमारे सामने एक एनिमी होता है, दुश्मन होता है, यहाँ पर कैंसर के सेल हमारे लिए दुश्मन है। और जैसे उस दुश्मन को नाकाम करने के लिए हमें, हमारे पास में काफ़ी हथियार होते हैं। वो हथियार है तरह तरह के हथियार, कीमोथेरेपी और रेडियोथेरेपी या टारगेटेड थेरेपी या इम्यूनोथेरेपी। और वैसे ही जैसे जंग में होता है, एयरफोर्स होता है, बोफर्स जैसे गन्स होते हैं, दूर दूर फेंकने वाले बॉम्ब होते हैं, छोटे वाले गन्स होते हैं, ग्रेनेड्स होते हैं, तरह तरह के। और जब भी कोई जंग लड़ाई जाती है, सबसे पहले एक स्ट्रैटेजी बनाई जाती है। आपने सुना होगा कारगिल वॉर में जब पूरे जब लोग काफी ऊपर थे, पेशेंट्स मतलब यानी कि एनिमी जो काफी ऊपर थे और ऊपर से नीचे ये बॉम्ब फेंक रहे थे हमारे जवानों के ऊपर, उनके बहुत मुश्किल हो रहा था। तो उन्होंने एयरफोर्स एम्प्लॉय किया पूरा वहां पर उनको खत्म करने के लिए, एयरफोर्स, बोफर्स, ये सब किया था। उससे उन्होंने काफी न्यूट्रलाइज किया, उसके बाद में इन्फेंट्री गई है। उसी तरह से हम लोग भी हथियार करते हैं और हर एक जंग में, हर एक यानी कि हर एक पेशेंट में हथियार अलग अलग तरीके से, वही हथियार यूज करेंगे। पहला कौन से यूज करेंगे, बाद में कौन से यूज करेंगे, और उसके बाद में और कौन से यूज करेंगे, वही एक जंग की लड़ाई स्ट्रैटेजी जो ये करते हैं। तो एक तरह से मैं कहूँगा कि चाहे कीमोथेरेपी हो, चाहे टारगेटेड थेरेपी हो, चाहे सब कुछ, हम लोग हथियार एक बॉम्ब के जैसे ही इस्तेमाल करते हैं, छोटे बॉम्ब, बड़े बॉम्ब, मैंने इस तरह से।
Fantastic, sir. So again, just for the more elucidation, you know, we use specifically in lung cancer. You know, we keep talking of lung cancer. The reason is very simple. Lung cancer did not have treatments. Now we know that if you are looking for a specific mutation in lung cancer, we have more than 10 to 15 mutations. And more importantly, we have drugs that can act in these mutations. And probably for all of us, the most important thing, all of these drugs are available in India now. For us, that makes a huge difference. So that patient comes to us and we tell them, look, you have this mutation, I'm going to give you a tablet or I'm going to give you one injection, which will not affect the rest of your body, but will affect this. That's where targeted therapy and precision medicine is taking us. And in this context, I think the next biggest thing that we talk of is immunotherapy. I think immunotherapy is the title of today's talk, and we have all spoken about it. So, Dr. Rangarao, in context of oncology, what exactly are you talking about when you say immunotherapy?
Right. So immunotherapy ये आए क्यों, मतलब इसमें एक सबसे पहले तो जान ले कि कैंसर और इम्यूनिटी में काफी इम्प्रूवमेंट, मतलब काफी रिलेशनशिप है। यानी कि अगर पेशेंट की इम्यूनिटी अच्छी होती है तो कैंसर नहीं होगा, और अगर अच्छी इम्यूनिटी है तो कैंसर को भी जीता जा सकता है। वो एक सिंपल बेसिक प्रिंसिपल है। वो हम लोग कैसे जानते हैं, ये काफी हद तक सही है, पूरा सही नहीं, काफी हद तक सही है। और वो कैसे जानते हैं हम लोग, जिनमें इम्यूनिटी कम होती है, जैसे स्टेरॉइड्स लेते हैं पेशेंट्स, कोई इम्यूनोसप्रेसिव ड्रग्स लेते हैं, या एड्स की जैसी बीमारी होती है, उन सब में कैंसर ज्यादा होता है। जब भी कोई तरह से इम्यून, इसका मतलब ये है कि कैंसर जब होता है, कुछ कमियां हो जाती हैं पेशेंट में इम्यूनिटी की। और वो क्यों होता है, कैंसर खुद एक इम्यूनिटी को सब कुछ तरह से पैरालाइज करता है या उसका प्रभाव कम करता है। यानी कि एक अगर हम लोग एक एग्जांपल दे दें मतलब एक करप्शन कर देता है, मतलब एक सिस्टम में करप्शन कर देता है, दुश्मन में जैसे करप्शन करता है वैसे ही इम्यूनिटी में करेक्शन करता है, जिससे इम्यूनिटी कैंसर सेल को मारा नहीं जा सकता है। तो बेसिक इंपॉर्टेंट चीज हमें जानना है कि हमारी इम्यूनिटी कैंसर को सेल को हटाने के लिए, कैंसर सेल को मारने के लिए काफी होता है, बट कुछ 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 कारण की वजह से वो इम्यूनिटी की खराबी होती है, और उस इम्यूनिटी को ठीक करना ही एक तरह से इम्यूनोथेरेपी है। और उसमें ये जानना है कि किस प्रकार का इम्यूनिटी हमें कमी है या स्ट्रेंथ की ज़्यादा ज़रूरत है, उस तरह से हम लोग इम्यूनोथेरेपी करते हैं। तो इम्यूनोथेरेपी तो बहुत तरह के होते हैं, और जो आजकल इम्यूनोथेरेपी हम लोग यूज़ कर रहे हैं वो एक तरह का इम्यूनोथेरेपी है, जिसमें कि हम लोग एक जो कैंसर सेल नॉर्मल सेल को रोकता है कैंसर सेल को मारने के लिए, उस रुकावट को हम लोग निकाल देते हैं। ये जो आजकल इम्यूनोथेरेपी दे रहे हैं, जो इम्यून चेक पॉइंट इनिबिटर्स, वो है इम्यून।
So, Dr. Piyush, I think Sir was talking about different types of immunotherapy, and he made a very important point. Immunity is something in the body which fights cancers. And when that immunity is hampered, that's when cancer cells start growing. And now, what we are trying to do is make the immune cells become active and start fighting the cancer again. It is like giving support to somebody who is being attacked by cancer, to take our analogy forward, and then making them stronger so that they can go back and fight against the cancer cells. So, Dr. Piyush, what are the immunotherapy types of drugs that we are really using? So, third, did allude to the fact that we are not talking of one drug alone, we are talking about a lot of variety of drugs. So, which are the immunotherapy drugs that we are using in oncology today? If you can throw some light on that.
Yes. So thanks for the question, Dr. Vamshi. So we are using basically right now, and this has been successful in today's practice, is immune checkpoint inhibitors. Now, it is as simple as something that our immune system, what Dr. Rao just said, it is good enough, it is competent enough to take care of cancer, but cancer actually it has made it indolent, or it has overwhelmed it. So because of that, our immune system is not able to remove cancer, defeat cancer. But once, if in case we use this particular drug, this brake system, the braking of the cancer, the brake which cancer has put on the immune system, this gets released. And the release of this brake, these checkpoint gets released, and these are immune checkpoint inhibitors. So the immune system then again sort of erupts, and it erupts against cancer. So this is what we use, immune checkpoint inhibitors, also called PD-L1 or CTLA-4 inhibitors.
Perfect. So now we are talking of some technical terms, and this is again something we need to hear, because always in the Google or whatever, you keep hearing these terms. So for the benefit of the audience, PDL1 is nothing but it's a short form. It stands for programmed death. So what this does is, the T cell in our body normally will kill a cancer cell, but the same T cell can go and attack our normal body cells also. So what our normal body cells have done is they have evolved a method wherein they activate this PDL1 and tell the T cell that, look, we are your friends, so do not attack us. And the T cell backs down. Cancer cells, being very smart, actually have adopted the same mechanism. And they then signal to the T cells saying that we are your cells. So they're hiding as if they are our own body cells. Therefore, the immunity will be ineffective and won't be able to act. The way to counter that is we use drugs that will block this PD1 or PDL1, and therefore the immune cells become active. So I think that's a simple way of putting as to what immune checkpoint inhibitors are. It's a very, maybe a bad analogy, but a very famous analogy will be the movie Sholay, where Thakur was going and killing Gabbar Singh. Gabbar Singh came and took off his hand, said, "Ye haath mujhe de de, Thakur." And Thakur could not do anything. But he got his friends, Jay and Veer aage, uske do naye haath, and then he went and goes and kills Gabbar Singh again. So, something like that, our immunotherapy is helping our T cells attack the cancer cells. So that, in essence, a very simple explanation of what immune checkpoint inhibitors are all about. Dr. Ranga Rao, sir, other than immune checkpoint inhibitors, any other way of activating of immune therapies that we are using now against cancers?
So एक नया तरीका है जो CAR T cells हैं, जो से that's an important thing in the sense कि एक simple example देता हूँ. मान लीजिए कि हमारे पास दुश्मन है, और दुश्मन को खत्म करने के लिए हमारे पास में पुलिस है, वो पुलिस बिल्कुल नाकाम हो गया है, बिल्कुल बिल्कुल बेकार हो गया है, बिकॉज ऑफ दी कैंसर सेल्स हैव कुछ इन्होंने प्रभाव किया है, मैजिक किया है कि ये बिल्कुल निकम्मे पड़े हुए हैं। तो उनको बाहर ले जाके ट्रेन करके हथियार दे करके वापस हमारे इसमें सिस्टम में डालना है। दैट्स एग्जैक्टली पार्टी सेल्स, मतलब हमारे जो उनको ट्रेनिंग दिया है, हथियार दिया है, उनको समझा है कि ये दुश्मन है, जाके मारो। एंड दैट इज एग्जैक्टली व्हाट इज कार-टी सेल थेरेपी। तो उनको उनके सेल्स निकाल के, टी सेल्स निकाल के बाहर, एंड बाहर उनको स्टिमुलेट करके, एक्टिवेट करके, साइटोकैन देके वापस उनके पास दे दिया है, ताकि वो कैंसर सेल को अटैक करके निकाल दे। वो एक तरह से सेलुलर थेरेपी है, बहुत इंपॉर्टेंट, काफ़ी सक्सेसफुल रहा है। लुकीमिया, ब्लड कैंसर जो ठीक नहीं होते हैं, उनके अंदर में कुछ क्योर हो रहे हैं, तो बहुत इंपॉर्टेंट चीज़ है। सो ये अभी काफ़ी महंगा है। अभी रिसेंटली एक केस अभी कुछ ट्रीटमेंट हुआ है टाटा मेमोरियल हॉस्पिटल में, एंड उसके लिए भी और आगे रिजल्ट्स के लिए हम लोग देखेंगे।
Fantastic, sir. Dr. Piyush, ये सब new things we are reading. We are talking about CAR T cells. What about cancer vaccines? Because vaccine is something which all of us know. I'll talk about it, COVID-19 a bit later on, but just otherwise, cancer vaccines. Anything that we can use right now, or where do you see it working?
So cancer vaccine, Dr. Vamshi, is actually still to therapeutic cancer vaccines when I say.
Yes.
So there are right now the cancer vaccine which is being used is sort of in prevention right now, to prevent, and that the most important one is the cervical cancer vaccine that's being used to prevent cancer to happen. But for the cancer which is already existing, the cancer vaccine is still to evolve. That sort of vaccine has certain challenges because of the autoimmunity. It becomes a real challenge to stop. So that is the major challenge. But the research is happening at a very good pace, and we hope to get some good results, especially in breast, in brain tumors, melanoma.
So I think again the way to simplify it is, vaccines work against one class of and viruses. All viruses are similar. So you take one common feature and attack it. Unfortunately, all cancers are different. We know that they have some common characteristics, but all of them behave differently. All of them are independent because each of them is coming from a different person. So you cannot use a single vaccine which will cover everybody, and inventing an individual vaccine is sort of what Dr. Rao was talking about a CAR T cell therapy. So that's in short. So, for those people who don't understand why we don't use a vaccine, very, very simply, we are talking of different cancers in different people. You need an individual vaccine for each of them. So we are getting some questions too, which I will be taking later. So it's interesting to note that the most common immunotherapy that we are talking about now, though we have these new stuff, the commonest one which is acceptable, which is available to us, is the immune checkpoint inhibitors, the PD-1, PD-L1. And that is really the focus. So when somebody comes and tells us immunotherapy, that is what we are talking about. The history of immunotherapy is very interesting. In fact, I don't know how many of the audience is aware. In 2018, the Nobel Prize in Medicine was given to two gentlemen, Jim Allison and a Japanese researcher, who were the ones given for first identifying this PD-1, PD-L1 interaction, and were responsible for getting this whole PD-1, PD-L1 immunotherapy on the path. So, that's where the Nobel Prize has even recognized this whole immune checkpoint inhibitor therapy. So I think for the rest of the talk, whenever we talk of immunotherapy, we are talking about immune checkpoint inhibitor therapy. So Dr. Rangarao, where are we using this immune checkpoint inhibitors now in cancers?
Yeah, so कई cancers में, खास करके lung cancers, melanoma में, kidney cancers, bladder cancers, esophageal cancers, and now gastric cancers, इन सब में काफ़ी यूज़ हो रहा है, अकेले में या कॉम्बिनेशन के साथ में, कीमोथेरेपी, रेडिएशन इनके साथ में, और कई सेटिंग्स अभी नए नए हो रहे हैं। पहले तो हम लोग हमेशा नए दवाई जब भी आता है वो स्टेज 4 में ही यूज़ किया जाता है, सेकेंड लाइन में, यानी कि 2-3 ड्रग फेलियर होने के बाद में धीरे धीरे उसका प्रमोशन होकर के क्यूरेटिव सेटिंग्स में आता है। और आजकल थोड़ा सा इम्यूनोथेरेपी इज कमिंग टुवर्ड्स द क्यूरेटिव सेटिंग, थोड़ा सा भी इसमें और टाइम है अर्ली स्टेजेस में लाने के लिए, बट स्टेज 4 में, स्टेज 3 में तो आ चुका है कई कैंसर स्टेजेस में। सो आई थिंक आगे जाके रिसर्च जैसे जैसे होते जाएगा हम ये देखेंगे कि इम्यूनोथेरेपी का प्रमोशन हो जाएगा करीब करीब सभी कैंसरों में, एंड देन उनका वो अर्ली स्टेजेस में भी यूज़ करेंगे। आशा यही करते हैं कि क्योर काफी करेंगे और थोड़ा सस्ते हो जाएंगे ताकि सभी लोग यूज करें और उसका फायदा उठाएं.
Perfect, sir. That's a very encouraging words. Dr. Piyush, where are we using immunos? And more importantly, is it a broad spectrum which you can use everywhere? All cancers, because everyone comes and asks us immunotherapy here. So can you just elucidate a bit on where it is working and where we think it works?
So that's a very important question, Dr. Vamshi. It is not for all cancers that you can use immunotherapy. There are what we call as immune hot tumors. So यानी कि ये ट्यूमर्स ऐसे होते हैं जिसमें इम्यून सेल की मात्रा काफी ज्यादा होती है. हमारे इम्यून सेल्स जो होते हैं वो ऑलरेडी उपस्थित होते हैं. So these are immune hot tumors, and then there are immune cold tumors where the immune cells are not very much in population. So the immune hot tumors usually, or otherwise very mutated tumors, these tumors are most commonly like melanoma, kidney cancers, lung cancer, so bladder cancer. ये tumors में already जो रहता है immune cells population ज़्यादा रहती है, and therefore most of the times we can use immunotherapy in these sort of cancers. But then there are cancers like breast cancer, which is estrogen positive, खास तौर पे estrogen positive tumors. So there you would not have much of immune cells. So we must discuss with the oncologist that where immunotherapy, it is not in all patients where we can use.
I think Dr. Rangarao, this is something which Piyush has brought out is very important. Discuss with your oncologist, because immunotherapy works well, immune checkpoint drugs work well, but they work well when you compare them to something else like a chemotherapy. Often I think there's a misunderstanding that immune checkpoint inhibitors are a panacea, they work everywhere and they work fantastically. The doctors, we say that they work well. What exactly, how would you quantify this just for the audience listening?
Yeah. So जो भी ट्रायल्स करते हैं उसमें उनका मेजरिंग पॉइंट होता है कि इससे ये फायदा हम लोग मेजर करना चाहते हैं. तो एक तो ट्यूमर श्रिंकेज यानी कि रेस्पॉन्स, दूसरा पेशेंट ज़्यादा समय के लिए जीता है, श्रिंक होने के बाद में थोड़े ज़्यादा समय के लिए जीता है, फिर से ट्यूमर बढ़ेगा नहीं, कम होते जाएगा और एक तरह से स्थगित हो जाएगा. वो एक पॉइंट है, यानी कि स्टेबल डिजीज जैसे हम कहते हैं, पार्शियल रेस्पॉन्स कहते हैं. वो रेस्पॉन्स काफ़ी देर तक कायम रहता है, दैट इज कॉल्ड एज ए ड्यूरेशन ऑफ रेस्पॉन्स. एंड पेशेंट कितना समय तक जीता है बीमारी के साथ या बीमारी के बगैर. तीसरा लास्ट है कि क्वालिटी ऑफ क्वालिटी ऑफ द पेशेंट, क्वालिटी ऑफ केयर. सो इन क्वालिटी ऑफ लाइफ, एंड उस समय पेशेंट का कंडीशन कैसा है, क्वालिटी उसका तबीयत पहले से अच्छा है कि नहीं, और इस ट्रीटमेंट से कोई खराबी तो नहीं हुई है. ये सब पैरामीटर्स से माना जाता है, देखा जाता है, नापा जाता है, स्टैटिस्टिकल इवैल्यूएशन होता है, उसके बाद में कहते हैं कि ये फायदेमंद है. अगर पेशेंट को जो हम बोलते थे बहुत फायदा करता है, पेशेंट सबसे पहले सोचते हैं मैं क्योर हो जाऊंगा. आई थिंक दैट इज द बेसिक डिफरेंस. हम लोग जो काफी फायदा करते हैं, हो सकता है हम लोग कहें जैसे अभी एक गैस्ट्रिक कैंसर में इम्यूनोथेरेपी आए हैं, अभी मैं यही देख रहा था कि उसका जो फायदा है 1.5 महीने का, एक ट्रायल में 1.5 महीने का फायदा है. अगर मैं उस पेशेंट को बोलूँ ये अभी नया दवाई है, बहुत फर्क पड़ता है अंदर में जानते हुए 1.5 महीने, सो आई एम नॉट बीइंग ऑनेस्ट. सो जो भी हम कहना चाहेंगे पेशेंट को भी जानना चाहिए इम्यूनोथेरेपी से क्या फायदा होगा. अगर लेंगे तो क्या फायदा होगा, नहीं लेंगे तो क्या फायदा होगा. इम्यूनोथेरेपी क्या मैं अकेले लूंगा या उसके साथ में कीमोथेरेपी या रेडिएशन या और कोई टारगेटेड थेरेपी लूंगा. सो इस तरह से हम लोग हर तरह से तोल के उनको बताना है. पेशेंट को बताना जरूरी है कि कितना फायदा वो एक्सपेक्ट कर सकते हैं, उनके एक्सपेक्टेशंस और वो जो रियलिटी ट्रायल का वो मैच करना चाहिए. उसमें अगर वो मैच नहीं करता है तो देन पेशेंट सोचता है कि मैं तो क्योर हो जाऊंगा, मैं तो इतने पैसे लगाए हैं. सो आई थिंक वो चीज़ हमें करेक्ट करना है. तो पेशेंट को अच्छे तरह से समझाना है कि क्या फायदा आप एक्सपेक्ट कर सकते हैं इसमें.
I think fantastic, sir. That is the key to explaining to patients. Dr. Piyush, we do often see this in practice. We are, as a doctor, even if 1 or 2 months is better, we would say this is a better drug. But so patients have to understand that by spending the money or by taking a new treatment doesn't mean you're getting cured. Even now, a lot of stage 4 patients will not be cured with immunotherapy. Yes, there's a small percentage which is tending to cure, but then not everybody gets cured. This is one point I think we should emphasize. I know all of us doctors emphasize, but I'm not sure how much patients understand this point. So Dr. Piyush, what's been your experience? Do patients really understand and accept this?
So, as you said, that because of the cost involved, the patients think at a point that this therapy would be exceptional. This therapy would cause will bring about great results. एकदम जो है जादू की तरह काम करेगा. But unfortunately, it is not the case. But having said that, it is true that in some small patients where we choose the patients correctly, or अगर वो ट्यूमर वैसा रिस्पॉन्सिव ट्यूमर है, it does convert a disease into a very chronic state. देखिए, stage 4 cancer, basically we tell, what we all tell is something where largely curative element might not be there, but chronic state, making a disease into controlled state is important. So that in some subset of patients is achieved, and not in all. But cure is, as you rightly said, that it's a single digit figure in some cancers.
Absolutely. So it is better, definitely, and definitely the quality of life, what Dr. Nangarao spoke about, is better. You know, the side effects of chemo and all are less, but we have to understand that it's not a magic pill. It does help a lot. It is a wonderful thing, and probably we're going to keep evolving with time, but it's not the magic pill that people sometimes take it for. So, Dr. Nangarao, sir, other thing that we need to understand, what all do you look for before you start a patient on immuno? I mean to say, is every patient fit for taking immunotherapy, or is it like whatever the condition of the patient? You know, we have people who come with patients on very poor condition, they can hardly walk to the bathroom, and and the attendants, one of the relatives want to know, can we take immunotherapy? So what are the things we need to look for before starting immunotherapy for a patient?
Right. अभी थोड़ी देर पहले हम लोग बात भी कर रहे थे, डॉक्टर पीयूष ने भी बताया था कि हर कैंसर में इम्यूनोथेरेपी काम नहीं करता है. कुछ कैंसर्स में काम करता है, कुछ कैंसर्स में नहीं करता है. सो जब पेशेंट को हम लोग चूज करते हैं और रिकमेंड करते हैं इम्यूनोथेरेपी आप ले सकते हैं, तो नंबर 1 पता करना है कि भी किस प्रकार का कैंसर है. दूसरा, वो कैंसर में कोई मार्कर्स हैं, यानी कि ब्लड जो टेस्ट होते हैं टेस्ट टिश्यू के ऊपर या ब्लड टेस्ट के होते हैं, कुछ मार्कर्स देख करके उससे पता लगा सकते हैं कि ये इम्यूनोथेरेपी इनमें काम करने की संभावना कितनी है. बिकॉज सबसे पहले ये जान ले कि हर पेशेंट को अगर इम्यूनोथेरेपी दिया जाता है, हर पेशेंट उसके फायदा नहीं होता है. कुछ को होता है, कुछ को नहीं होता है. अगर हम अच्छी तरह से सेलेक्ट करें बेस्ड ऑन दी मार्कर्स, मतलब कि पेशेंट को चूज करके ले लें, तो देन फायदा ज़्यादा होता है. इसीलिए पेशेंट को केयरफुली सेलेक्ट करना ज़रूरी है. किस प्रकार का कैंसर है, ये इम्यूनोथेरेपी इसमें काम करता है कि नहीं करता है. इस पेशेंट में जो ट्यूमर है, इसके ऊपर इम्यूनोथेरेपी काम करने का तरीका, लंग कैंसर होगा, कुछ काम करता है, कुछ नहीं करता है. वो मार्कर जैसे PD-L1 या ऐसे जो भी टेस्ट करते हैं, किसी कोलन कैंसर्स में MSI करते हैं, उस तरह से टेस्ट करके फिर हम लोग समझेंगे इनमें काम करने की संभावना कितनी है. तीसरा ये है कि इम्यूनोथेरेपी के अलावा और कोई ऑप्शन है जो उतना ही काम करेगा कि नहीं, वो ऑप्शंस पूरा जानना है. एंड देन चौथा ये है कि पेशेंट की कंडीशन अच्छी है या नहीं है, उसकी जो साइड इफेक्ट्स होते हैं वो टॉलरेट करने के, साइड इफेक्ट ज़्यादातर होते नहीं हैं, फिर भी देखना पड़ता है कि इनमें ऐसा कोई कॉन्ट्राइंडिकेशन तो नहीं है, कोई ऑटो इम्यून डिजीज तो नहीं है, कोई ऐसा तो नहीं है. तो वो सब देख करके फिर हम लोग. एंड देन लास्ट एंड मोस्ट इम्पॉर्टेंट, क्या ये पेशेंट इम्यूनोथेरेपी का कॉस्ट उठा पाएंगे. और एंड वन मोर इम्पॉर्टेंट थिंग जस्ट नेक्स्ट टू दैट पॉइंट इज, क्या ये पेशेंट को समझ में आया है कि नहीं इम्यूनोथेरेपी कितना फायदा करेगा और कितना कॉस्ट होगा, यानी कि कॉस्ट एंड बेनिफिट. ये सब चीज़ें समझ के जब हमको यकीन हो जाता है कि हाँ ये समझते हैं, खर्चा उठा लेंगे, तब जाके हम लोग रेकमेंड करते हैं.
Fantastic, sir. So again, the take-home message is immunotherapy works well, but it is not for everyone. Make sure that the patient is fit enough to take it. And again, the question is simply asked. I think the easiest way to ask, patient is bedridden, not even able to walk up till the bathroom. I mean, even though immuno might not cause side effects, it's very unlikely to work. And that is something we tend to forget when we have health issues. And the reason is very simple. A lot of people want simpler answers, which unfortunately are not available. And out of desperation and out of some hope, we can try medicines sometimes, but we should be aware that they may not work. I think that's a very important take-home message from all of us here, that use the drugs in the right patient, they really do well. Using in the wrong patients may not really achieve much thing. So having said that, I think we have been a little bit gloomy and a little bit dull about the prospects of immunotherapy, or trying to be cautious. So let me try to turn the topic to a more positive side. Dr. Piyush, What has been your experience with immunotherapy? Any results which were really satisfying? And what has been your experience in terms of the side effects? Do you think patients are able to tolerate it? Can you just give us some example or some idea of this?
Okay, so immunotherapy, my experience has been so far that if wherever the patient, the immune marker was positive, and one immune marker is MMR deficiency, mismatch repair protein deficiency. So it is again a sort of good marker if it is deficient. And my patient was of a colon cancer, and she was 80 plus, and she was able to take care of herself. Activity of daily living was quite well, she was able to do that. So here I used immunotherapy, and she is doing quite well. She comes and takes it all throughout the COVID period also. She got vaccinated, and thereafter she's continuing immunotherapy with a good disease response. So with chemotherapy, I wouldn't have sort of thought about these sort of compliance with the patient, nor side effect profile would also have been harsher on a 80-year-old. So immunotherapy works well where the patient is chosen correctly, as the previous message was.
Fantastic. So I think some such examples are there. Dr. Rangarao sir, any such example for you when you had a very satisfying result after using immunotherapies?
Right. So जब ये immunotherapy नया नया आया था, I think about 6 years back, 6 साल पहले आया था, the first molecule. तो एक patient आए थे हमारे पास में, बुजुर्ग, मतलब about that time he was about 70 years old, and then उनको lung cancer था, 2 तरह की chemotherapy दे चुके थे, and then देने के बाद में उनको ज़्यादा फायदा नहीं हुआ था, और वो चल भी नहीं सकते थे जब हमारे पास में आए थे, और व्हील चेयर में आए थे, सिर्फ एक ओपिनियन लेने के लिए कि कुछ और किया जा सकते हैं या इनको अपने इसमें किस्मत में छोड़ना है, ये बड़ा सवाल था। तो उन्हीं दिनों में हम लोगों ने इनको जब देखा, और इम्यूनोथेरेपी आई था, मार्कर्स वगैरह उस समय ज़्यादा प्रैक्टिस नहीं किया जाता था, उन दिनों में मार्कर्स की नॉलेज इतनी नहीं थी, एंड इनमें वो रेलिवेंट भी नहीं था, क्योंकि ऑलरेडी 2 लाइन के कीमोथेरेपी ले चुके थे। मार्कर यून हो या नहीं हो, इनको कीमोथेरेपी एक सिंगल एजेंट दिया जा सकता था, और इनको लंग प्रॉब्लम भी था। हमने पूरा इनको इवैल्यूएट किया, वो इम्यूनोथेरेपी के लिए फिट थे। और दूसरा, जो उनकी कंडीशन तो काफ़ी थी कि जो इम्यूनोथेरेपी ले सकते थे, तो हमने उनको इम्यूनोथेरेपी देना शुरू किया। शुरू में थोड़ा सा प्रॉब्लम हुआ, उनको साइड इफेक्ट्स हुए थे, स्किन रैश हुआ था, थायराइड का प्रॉब्लम हुआ था बाद में जाके, और धीरे धीरे जैसे जैसे इम्प्रूवमेंट होता गया, वो कैंसर भी कंट्रोल में आए हैं, और अभी उनको करीब 76 इंजेक्शंस लग चुके हैं, पहले 2 साल में हर 2-2 हफ्ते में। और उसके बाद में हमने सबसे पूछा 2 साल के बाद में क्या करें, इनको किसी को नहीं पता कि 2 साल के बाद में क्या करना है। फिर हमने सबसे बात करने के बाद में उन्होंने बोला कि अब अपना तरीका ढूंढिए, तो 1 महीने में 1 बार, एंड 1 महीना वो भी हो गया 2 साल, उसके बाद में नाउ 2 महीने में 1 बार। क्योंकि अगर छोड़ दूं मैं इम्यूनोथेरेपी, तो हो सकता है कि ये बीमारी एकदम वापस आ जाए तूफान के जैसा, और उनको कुछ खराब करे उनकी तबीयत। इसी भय से हम लोगों ने इम्यूनोथेरेपी छोड़ा नहीं है, और पेशेंट ने भी बोला कि सर हमको कोई तकलीफ नहीं है। एंड मैं सबको एक ही एग्जांपल देता हूँ, जब वो हमारे पास आए थे, व्हील चेयर में आए थे, और अभी जब पेशेंट आते हैं, हमारे कमरे में आते हैं, तो सब पेशेंट, मतलब कोई भी जो हमारे साथ में होते हैं, देखते हैं पेशेंट कहाँ है, उनके पीछे देखते हैं, क्योंकि वो इतने अच्छे कंडीशन में है, इतने अच्छे कंडीशन में है, ना पेशेंट दिखते हैं ना कुछ, हंसते हंसते। 75 ईयर्स के अच्छे खासे रिटायर्ड आर्मी पर्सन है, ऑफिसर, उनका बेटा भी एक सर्विंग ऑफिसर है। वो आके जब मेरे से बात करते हैं, और कर्नल साहब क्या हो रहा है, तो इतने अच्छे से बात करते हैं। मैं सबको ये देता हूँ, अभी जाके गोल्फ खेलते हैं। सो फ्रॉम व्हील चेयर टू गोल्फ इज माई स्टोरी विथ हिम, एंड आई थिंक वो, बट एक चीज इंपॉर्टेंट, ये ऐसा वाला रिस्पॉन्स हर एक पेशेंट में नहीं होता है। एक पेशेंट में हुआ है, इसका मतलब ये नहीं कि हर पेशेंट में ये होगा। ऐसे वाले पेशेंट शायद मुश्किल से 100 में से 2 या 3 होंगे, ज़्यादा नहीं होंगे। सो ये जो चीज़ है, ये दिस इज द बेस्ट थिंग दैट आई कैन थिंक ऑफ। Probably he is one of the longest benefactor of the immunotherapy to my mind. I am not sure with anyone else has got such a long, long living patient. So that's one of the experiences. And then ऐसे कुछ बहुत सारे और भी किस्से हैं, but that is one important thing which I quote.
Very nice story, sir. It is very heartening. I think now the audience will understand why sometimes oncologists want to give, because we see one or two of these patients, they do well. We have to remember, like Dr. Ankarao said, not everyone is going to do so. And that is something we do tell patients that, look, we will try, and maybe it might be a miracle, but it doesn't happen in every case. But yes, I think all of us have these handful of patients who have really done better than you expected, and they're very grateful that they're not having issues and they're quite happy. So it's very gratifying to treat such patients. So Dr. Angarwal, if I can ask you another question as to what are the precautions you take while patient is on immunotherapy? Because again, very common doubt that patients have. What should I do and what shouldn't I do during immunotherapy?
Right. So इम्यूनोथेरेपी के टाइम में क्या क्या साइड इफेक्ट्स होते हैं, उन सबका हमारे पास लिस्ट है. सो एक मतलब कुछ ब्लड टेस्ट करते हैं, उसकी फिटनेस देखते हैं, हार्ट का फंक्शन, किडनी का फंक्शन, लिवर का फंक्शन, थायराइड फंक्शन अच्छी तरह से इवैल्यूएट करते हैं ताकि ये सब चीज़ नॉर्मल है. एंड देन कुछ टेस्ट रिकमेंडेड हैं वो साथ साथ में करते जाते हैं. हम उनका जो भी साइड इफेक्ट्स है हर बार रिव्यू करेंगे, उनको कोई साइड इफेक्ट तो नहीं हुआ है. एंड लेट मी मतलब सबको ये मैं बता दूं कि हमें साइड इफेक्ट के बारे में काफ़ी जानकारी है साइंस में सर एक को, कि साइड इफेक्ट्स क्या होते हैं वो एक अर्जे तक 2-3 साल तक शायद उसके रिकॉर्डेड हैं. उसके बाद में कोई और लंबे साइड इफेक्ट्स होते हैं, क्रॉनिक साइड इफेक्ट्स और लॉन्ग टर्म साइड इफेक्ट जो कहते हैं हम लोग, उसकी इतनी नॉलेज नहीं हो रही. जैसे जैसे एक्सपीरियंस बढ़ते जाएगा शायद हमें पता चल जाएगा. तो जब भी कोई पेशेंट इम्यूनोथेरेपी पे होता है उनको हम लोग मॉनिटर करते हैं ताकि कोई साइड इफेक्ट ना हो, और साथ साथ में ये भी देखते हैं कि उनका इम्यूनोथेरेपी का जो प्रभाव कैंसर के ऊपर है वो कैसा है, देख करके उनको अच्छा हुआ बुरा हुआ. जब भी इम्यूनोथेरेपी खराब होता है, मतलब कैंसर खराब होता है, तो फिर हम लोग रिकमेंड करते हैं. जिस तरह से बीमारी का अंदाजा लगाया जाता है इम्यूनोथेरेपी में, उसमें और कीमोथेरेपी के साथ में बहुत फर्क है. कुछ क्राइटेरिया हैं जो रेडियोलॉजिस्ट और न्यूक्लियर मेडिसिन स्पेशलिस्ट और ऑन्कोलॉजिस्ट समझते हैं, वो क्राइटेरिया बिल्कुल अलग है. पेशेंट सबसे पहले ठीक होना चाहिए, दैट्स द मोस्ट इंपॉर्टेंट थिंग. उनकी कोई तबीयत में खराब नहीं होना चाहिए, पहले से अच्छे होना चाहिए. साथ साथ में उनके जो कैंसर कंट्रोल में होना चाहिए और साइड इफेक्ट ना होना चाहिए. ये सब चीजें हम लोग मॉनिटर करते हैं.
Dr. Piyush, this is what doctors do. We monitor patients. We will make sure that things are not going bad. We tell patients to let us know. But the more common question, what food should I take? What food shouldn't I take? And the Indians being what we are, we get all these ideas. Nahi, adrak khayenge to it is good for immunity. Lemon if you eat, you won't get immunity. Things like that. So what is your advice regarding food habits for patients?
So I simply tell my patients that follow what your natural dietary patterns are. Do not think of too many new food items or exotic. Sometimes patients say that a fruit from Brazil or which could rather be enhancing the immune system. So just what your seasonal fruits, vegetables available in your region is, that is the best thing that you can do. And don't think overtly otherwise. And I usually suggest that to avoid red meat for the reason that a bit of colitis or indigestion, gastritis could be there. But otherwise, white meat or eggs are absolutely okay. More of fiber diet, and that basically is going to enhance your gut immunity. So gut immunity is better, so does the immunotherapy would act better. Yeah,
absolutely. I think we should just encourage normal diet, and normal means what everyone is eating. There is no need to make a special food for you. I mean, you don't need to be treated very specially, given extra food. And the same thing with someone like you asked, if they say Brazil se fruit, my automatic reaction is Brazil mein cancer nahi hota hai kya? It's fruit se avoid hota to nobody would have it. I mean, the idea is these foods are good. But a lot of these foods are important in the Western society where people eat a lot of processed food. Mostly in India, we all go to the neighboring market, buy fresh vegetables and fruits and eat it. Even non-veg food, many people would actually buy fresh meat rather than those stored, frozen and all that. Remember, whenever we take stored foods, they are adding preservatives which are harmful. But if you're buying fresh vegetables, fresh fruits, there's nothing like that, and there's no special diet needed. Again, dry fruits, something all patients ask us, dry fruit kha sakte hain kya? And we are like, okay, eat it. If you eat more of them, it will not hurt you. It will not help you. Remember, our body has a very good system. If you eat more of something, it simply passes it out. It does not take it inside the body. And our body is very good and accustomed to doing what it has been from the childhood. So, Dr. Piyush, other than that, I know Dr. Angarao पे एक patient जाके golf खेलने लगे, but other than that, is there anything that you suggest to patients to avoid? Any activities that you should not do? Anything which you should be away from? Because again, this is something that patients want to know.
So I think there are no scientific basis of what I'm telling, but yes, in a sense that we have some data, basic scientific data to say that living a healthy life, incorporating exercise, all this is going to enhance your innate immunity, your basic immunity, sleeping habits, avoiding alcohols, and of course, a big no to smoking. So these are what are the precipitators of, this is what precipitated cancer. So that absolutely needs to be avoided. So stress, anxiety, and diabetes needs to be under control, which is very important. So these are important things. Certain things, as in if in case there is an infection, consult your doctor before you use an antibiotic. If in case you are having some autoimmune disease like asthma, then steroids, just consult your doctor before you start using steroid. So usage of steroid is one particular medication which can hamper and certain antibiotics can hamper the effect of immunotherapy.
Perfect. So I think these are all again things we do discuss, but most of patients I tell them try to lead as normal a life. Do not make a life complicated. Try to lead it normally and spend good time with your family. I think that's the most important take-home message. So coming to a different topic which somebody has asked us also, Dr. Rangarao, you're senior. You see these patients coming and anything which has the word immune in it, they think is the same as immunotherapy. And unfortunately, there are a lot of these kind of self-advertised immune treatments available for patients. What do you think of those kind of things?
Yeah. So एक मिसनॉमर है, एक मतलब गलतफहमी पैदा करते हैं, इंटेंशनली भी करते हैं, कुछ अनइंटेंशनली भी हो जाता है। गूगल में पढ़ते हैं, एडवर्टाइजमेंट पढ़ते हैं, अभी आप रोड पे जाएंगे दिल्ली में कहीं पे बहुत जगह है, इम्यूनोथेरेपी अगेंस्ट कैंसर वो लिखा जाता है, ये सेल थेरेपी अगेंस्ट कैंसर, जो कि जैसे वो नाम पढ़ते हैं इम्यूनोथेरेपी ऑफ कैंसर, वो सोचते हैं कि ये इम्यूनोथेरेपी और ये हमारा इम्यूनोथेरेपी सेम है। इसमें काफी फर्क है। वो जो इम्यूनोथेरेपी बोलते हैं बिल्कुल अलग चीज है, डेंड्राइटिक सेल थेरेपी बोलते हैं वो बिल्कुल अलग है। तो इसके बारे में मैं बुराई तो नहीं करना चाहता, बट वो साइंस नहीं कहता है कि वो प्रूवन है। एंड देन वन मोर इम्पॉर्टेंट थिंग जो अभी हम लोग बातचीत कर रहे थे कि इम्यूनोथेरेपी के साथ में और क्या क्या करना चाहिए। नंबर वन इम्पॉर्टेंट थिंग इज इम्यूनोथेरेपी जब फायदा करता है शायद लंबे समय तक चलेगा, उसकी कॉस्ट और उसके साइड इफेक्ट्स मॉनिटर करते रहेंगे, कभी कभी इंडेफिनिट पीरियड के लिए भी चला सकते हैं। अभी अभी धीरे धीरे एक्सपीरियंस आ रहे हैं, जैसे एक पेशेंट में मैंने बताया है, उनके स्टॉप नहीं कर रहे हैं। दूसरा चीज, बहुत सारे पेशेंट्स ऑल्टरनेटिव ट्रीटमेंट लेते हैं हमें बता के या नहीं भी बता के, दोनों तरह से। कुछ लोग बताते हैं, कुछ लोग नहीं समझते कि जरूरत नहीं है, वो उनको क्या पता, उनको अपना ट्रीटमेंट करना है तो हम अपना ट्रीटमेंट करेंगे, आयुर्वेदिक होम्योपैथिक। तो हमारा एडवाइस ये रहेगा कि दोनों को ट्रीटमेंट मिक्स मत करें, क्योंकि उसका जो इंटरेक्शन होता है बिल्कुल नहीं, तो उसको बिल्कुल अलग रखेंगे। So I think that's an important advice that we should give it to all patients.
Fantastic. Dr. Piyush, same thing somebody has asked us. What is dendritic cell therapy? Is it effective? And we hear all these kind of so-called immune therapies, and patients are told it will just make you immune booster, or it will make you stronger. It will make you feel better. It will reduce side effects. Is there any basis for accepting all of these? Should we blindly accept all of these things?
No, okay. So हम लोग बात कर रहे थे बॉम्ब्स की, हम लोग टाइम बॉम्ब ये बात कर रहे थे। एक होता है हथियार अच्छा सा जो जंग में अच्छा फैक्ट्री में बन के आता है, दूसरा गांव में बनाते हैं। दोनों में कितना फर्क है? वही फर्क जो ये जो देसी वाले डेंड्रेटिक सेल्स या इम्यूनोथेरेपी में है और वो जो प्रूवन वाले साइंस में है, उतना ही फर्क है। तो ये जो हम लोग जब बता रहे हैं साइंस के थ्रू इवॉल्व हुआ है, प्रूवन हुआ है, जहाँ कितना फायदा करता है, एक एक चीज को नापा गया है, उनमें ना कोई जान ना पहचान, वो सिर्फ देते रहते हैं। तो ऐसे मिथ्स पे, ऐसे मतलब मिसअंडरस्टैंडिंग से उसके ऊपर ना जाए। हर इम्यूनोथेरेपी सही नहीं है, जो हमारे जो इम्यूनोथेरेपी है वो बिल्कुल अलग है। और डेंड्रिटिक सेल्स हमारी बॉडी के अंदर नॉर्मल होते हैं, पर डेंड्रिटिक सेल्स जैसे बॉम्ब के जैसा होता है, डेंड्रिटिक सेल्स वो इम्यूनिटी को फायदा करते हैं वायरस को, बैक्टीरिया को, कैंसर सेल्स को हटाता है, बट उसको कैसे स्टिमुलेट करना है, कैसे चलाना है। एक रोबो को आप मतलब बैटरी लगा के चलाएंगे, दूसरा एक पूरा प्रॉपर रोबोटिक सर्जरी करते हैं, बहुत फर्क होता है। सो वो हर डेंड्रिटिक सेल ये इम्यूनोथेरेपी नहीं होता है। और दुनिया में जो डेंड्रिटिक सेल थेरेपी हुआ है कुछ में अप्रूव्ड है, जो प्रोस्टेट कैंसर में और कुछ और कैंसर में वो वेरी तरीके से बनाए जाते हैं और उनको ही अप्रूवल है। बाकी सब डेंड्रिटिक सेल थेरेपी कहते हैं, कुछ भी कहें, मतलब वो कहते हैं, बट वो सही, वो एक जैसा नहीं है।
Fantastic. So again, point is, we are not, no, I don't think any of us will say it's totally wrong. You do a proper trial, you do a clear-cut data ki haan, it is working in this patient, you know, we'll be happy to use it in the same patient. I don't think anybody will say don't use it. The problem is if you say this drug works in 100% of patients and will not cause any harm, I think that's where most of us are a little bit worried, and unfortunately patients believe that and take something. So Dr. Piyush, what's...
So,
yes, sir.
can I just tell one point
yes,
here?
Yeah,
because अभी जो कोविड के टाइम में काफी लोगों को समझ में आया कि क्लिनिकल ट्रायल क्या होता है।
yes.
परसेंटेजेस, स्टैटिस्टिक्स बहुत अच्छी तरह से समझ में आए हैं उनको कि कितनी एफिकेसी है। वो बात करते हैं 72% उधर है, 78% इधर है, 80% उधर है, 90% इधर है। अब उनको नापना तोलना ये सब फायदा कैसे होता है सब समझ में आ रहे हैं। वैसे ही अगर आपको ये बताया जाए ये फायदा करता, कोई आपको कोई कंपनी वाला दे दे ये कोरोना वैक्सीन है, भाई कितना फर्क है, कौन सा डीएनए है, आरएनए वैक्सीन है, किस तरह का वैक्सीन है, अच्छा पता नहीं हमें किस तरह का, बट है वैक्सीन, बहुत काम करते हैं, कितनों में, 4 में आप वो वैक्सीन लेंगे। सो उसी तरह से ये दवाइयां भी बिल्कुल वैसे, ना नापा गया है, ना तोला गया है, ना रिसर्च कुछ हुआ नहीं है, उसके ऊपर आप कैसे विश्वास करेंगे। आप जो रिसर्च हुआ है उसके ऊपर आप विश्वास करने के लिए तैयार नहीं है और उसको विश्वास करना चाहेंगे जो जिसके ऊपर कोई ट्रायल नहीं हुआ, तो वो बिल्कुल गलत है।
Perfect, sir. Dr. Piyush, your take on this?
Yeah, I absolutely agree. I think so. There are some sometimes patients जो हमारी clinic में आते हैं and they tell कि उन्होंने dendritic cell therapy लिया. So unfortunately, these sort of therapies are not tested. No clinical trial. But of course, dendritic cell therapies पे clinical trials हुए हैं. So far, they haven't been so successful that they are in practice. But unfortunately, some people do practice it, and जब patients हमारे पास आते हैं कि treatment failure हो रहा है, dendritic cell therapy इतना पैसा खर्चा हो गया और वो नहीं हुआ, तो basically वही है that we need to understand that immune checkpoint inhibitors is the therapy which is tested, and now with the passage of time we have good data set. अब हमारे पास robust clinical data है that this is working. And now with the evolving, passage of time, we are trying to understand more molecular markers कि कहाँ किस कैंसर में ये बेहतर काम करेगी. So जो कि dendritic cell therapy के साथ तो एकदम अभी फिलहाल नहीं है knowledge. So that is important with every therapy to evolve.
Fantastic. So I think the bottom line is, if any untested therapy is there, if you are wanting to take part as a clinical trial, you want to, you should be aware of this fact. Do not blindly believe what anybody is telling you, and definitely, as they say, something that sounds too good to be true is definitely not true. Just because people think that आप बोलोगे 5 रुपए डालेंगे and आपको 5 लाख मिलेगा उसमें से, obviously होने वाला नहीं. Same way, if something is too good to be true, it's probably not true. So coming now to the final part of the last 5 minutes of our discussion, Dr. Rangarao, COVID-19 has completely upturned our lives for the last 1.5 years. It's something that none of us medical people ever saw, and we are all finding difficulty with. So in that setting of COVID-19, 2 questions which all patients want to know. Immunotherapy, can you continue it during the COVID-19 period? Can you continue it because COVID-19 is so prevalent? And number 2, what about vaccines if you're already taking immunotherapy? If you can take these 2 questions, and then I can ask Dr. Piyush to take the same 2 questions.
दोनों के लिए in short, yes. मतलब immunotherapy कोविड टाइम में ले सकते हैं, लेना चाहिए, continue it, and during immunotherapy you can take the vaccines and benefit from that. इससे ज़्यादा बहस करने की जरूरत ही नहीं. Yes and yes.
Fantastic. Dr. Piyush, which vaccine? Again, like sir was saying, everyone has become an expert on the road, and people are very knowledgeable now about Covaxin, Pfizer, Moderna, Johnson, and सब बोलते हैं. What is your advice? Patient कौन है, what vaccine can they take?
Whichever is available, whichever you get the first appointment, please go for it. Whichever vaccine is available to you, you must go and not wait for it. Is because of the simple reason कि ये 2 vaccine के बीच में जो है comparison नहीं हुआ है. ये जो कंपैरिजन है ये बेसिकली वैक्सीन ना लेने पे और वैक्सीन लेने पे है. सो वो वैक्सीन जो लिया गया है, every vaccine has shown a good efficacy. So please go for whichever is available to you.
Fantastic. So again, very important that vaccines have to be taken. जो भी मिले, and all said and almost all the vaccines are effective in preventing severe infections. That is important. Okay, there are people getting infected after taking vaccine. We are all aware of that. But however, most of those people are able to manage without hospitalization, without medicine. So that's the bottom line. Cancer patients are a unique category. Already the suffering is more. On top of that, however, if you get COVID-19, it impacts your treatment. But being afraid of COVID-19 and not taking your treatment is worse. You have to continue treatment with due precautions, with vaccination. That is the strong message going out. So it's been a fascinating discussion about immunotherapy, and I wish you could keep on talking, but we do have certain time limits, and I think we are close to an hour of discussion. So what I'll do is in the last 5 minutes, let me just take a few questions which have come here. One person wants to know what are the post-immunotherapy treatment precautions. We did discuss that, nothing in particular. Can someone take immunotherapy post neoadjuvant radiotherapy and surgical esophageal surgery? It's a very specific question. I think this needs to be really discussed with your doctor in detail. There are some trials on this which suggest that it could help. That's a short answer, but to discuss more, you really need to sit with your doctor and discuss this. Patients on treatment can take vaccine. Dendritic cell therapy, as we have all said, is experimental. As of now, we will not advise it as a standard of care. You want to take it as part of a clinical trial in a hospital, that's fine. But please understand that it is right now not certain if it is going to be effective or not. It may be effective, we are not denying that, but right now we do not know. Can a patient skip chemotherapy and take immunotherapy? I think Dr. Rangarao covered it very nicely that there are certain cancers where that works. In lung cancer, some patients with lung cancer, it will work. Talk to your oncologist, make sure you are in that category before skipping anything. Immunotherapy plus radiotherapy, again, a lot of data going on, a lot of trials going on. Probably 2 years from today, if we discuss this, we'll be in a better position to tell you. As of now, no. As part of a clinical trial, why not? As a routine, right now, we would suggest against it. And the final question was, can we ask some questions to a doctor about cancer or treatment and find out if the doctor is genuine? I think this suspicious mind should be avoided. Most doctors would want to treat you with the right spirit and the right attitude. Do not cross-question every doctor for that thing. I think that's a kind of a bad attitude there. As long as the doctor is a qualified oncologist, medical oncologist who has some good training and is aware of what drugs to give, I think you are safe in their hands. Unnecessarily questioning every doctor is not the way to go forward. That would be my take on it. So we do not have any other questions. And so Dr. Rangarao, sir, final words about immunotherapy and what patients should be aware of.
Yeah. So जब भी पेशेंट के लिए मैं यही राय दूंगा, जो भी ट्रीटमेंट लेंगे इंक्लूडिंग इम्यूनोथेरेपी, खास करके इम्यूनोथेरेपी की उसके कॉस्टली ज़्यादा है, अपनी ऑन्कोलॉजिस्ट से, अपनी ऑन्कोलॉजी टीम से अच्छी तरह से डिस्कस करें इम्यूनोथेरेपी क्या बेस्ट ऑप्शन है, इम्यूनोथेरेपी के अलावा और क्या ऑप्शंस हैं, इससे हमें कितना बेनिफिट मिलेगा, कितना एक्सपेक्ट कर सकते हैं, क्या हर बार हर पेशेंट को फ़ायदा होगा या इनमें फ़ायदा होगा, नहीं होगा, और वो क्यूरेटिव है कि पैलिएटिव है, ये सब क्वेश्चंस का आंसर समझ के फिर जाना. और कितना दूर तक, कभी कभी सिर्फ 1-2 डोज का ही कॉस्ट पूछ लेते हैं, एंड देन कभी अगर उनको ये बताया जाए कि हो सकता है 3 साल, उसके लिए तैयार हैं आप, सो वो चीज़ें उनको जानना ज़रूरी है. क्योंकि कई पेशेंट्स जो हैं पहले तो इंथुजियाज्म में ले लेते हैं और जैसे ही 3 महीने सर हमने तो ये नहीं सोचा था कि इतना महंगा है, और छोड़ देते हैं. तो यानी कि आपको अच्छे तरह से समझना है कॉस्ट इसका कितना होता है और इफेक्ट कितना है, उसका बेनिफिट आप अपने लिए अंदाज़ा लगा के फिर लीजिएगा, और उसके बारे में अच्छी तरह से सोच समझ के और कोई ऑप्शंस और हैं लेकर के फिर आगे बढ़ेंगे.
Thank you, sir. Thank you for those words. Dr. Piyush, final words.
Yeah, so as Dr. Rao said, important to discuss with your oncologist. There are certain parameters which needs to be looked into. One is the tumor-related parameters and one is the patient-related parameters. Of course, the economics play a very important part. It should not be leading to a financial toxicity. So that is what is important. Also, during immunotherapy, it is not a therapy which will cause effects within 1 or 2 cycles. It will take some time. It is going to take at least 2 to 3 months before it starts showing its response. and you should be ready to take it further if in case, at least for 2 years, if in case it starts showing response. Also, therapy पे जो tests हैं वो in particular diligently वो हमको करवाने जरूरी हैं जो डॉक्टर प्रिस्क्राइब करता है, क्योंकि वो बड़े इंपॉर्टेंट है. कई सारा फ्रॉम हेड टू टो कोई भी जो है साइड इफेक्ट इम्यूनोथेरेपी कर सकती है.
Fantastic. So, I mean, I don't want to talk more about only immunotherapy. One thing that is important for all our patients is definitely treatment has improved. We need to personalize treatment. We need to look at as treatment which is personalized, not just for the cancer and the patient, also for the entire family. Look at the social aspect, look at the financial aspect, have faith in your doctor, and definitely there is hope at the end of the tunnel. We are not talking of cure for all, but definitely improving quality of life with a longer life, with a longer survival is something that is feasible and that should be aimed for. So thank you very much, Dr. Rangarao. That was it was great interacting with you. Thank you, Dr. Piyush. I think it was nice talking to everybody, and hopefully the listening audience has found something. I thank Onco.com for organizing this Facebook Live session. So thank you, everyone, and good evening and good night.
Thank you.
Thank you, Dr. Vamshi, for conducting it so nicely. We've stopped the live stream, so
Yeah, good night, bye.
bye, take care. Thank you.